yeah, I think we'll get started after that. Think that I think that Dr. Harikaran is going to be joining us just a little bit late. But as soon as they join us, we'll just kind of tag team the questions. But for now, you can go ahead.
All right, good evening, everybody. Thank you so much for having me. My name is Atinga Ngurama. I am a medical intern at King Edward's Hospital, which is a hospital in Durban, Umbilo, KwaZulu Natal. Um, yeah, I think that's just pretty much it. Thank you for having me.
Thank you so much for joining us. I think that we can begin. If you could just begin by running us through what first year internship is like, what the rotations are like, what the calls in each rotation is like, the hours, the work environment, the kind of work that you do, those kinds of things.
All right, so yo, go rough. Guys, first internship is horrible. It's well, at least for me, it's been a rough ride. So I thought med school was bad, but yeah, no, first internship. I think people always say that the worst times in your life as a doctor is your internship, especially first internship and registrarship. And boy, they didn't lie. It just makes it better because now you're getting paid, but otherwise it's quite intense. I personally chose King Edward's Hospital for reasons that didn't have much to do with the hospital, but with where it is basically. So I started running businesses in med school, and one of those businesses was based or is based in Durban. So it just made a lot of sense for me to finish med school and stick around, and try and make sure that it's sort of running independently and sustainably without me. So like devote my time during internship to also focus on that maybe then ComServe, go explore other places. I studied in KZN, so I've been in KZN for about 7 years now. This is my seventh year. So yeah, it didn't really have to do with King Edward's. It had to do with just being in Durban, and King Edward's was the option that I was leaning more towards. One, before we even speak about the blogs and all of that, I wanted to talk about the communication prior to starting work. That's one thing I really, really loved, that by the middle of December-ish, we knew where we were going to start. We knew where we were allocated. We knew our teams. And a couple of days before the new year, we had an orientation, a virtual orientation, just taking us through. I studied in internal medicine, so just taking us through what the block is like, what's expected of us, and just introducing us to everyone. So I think that kind of like was a smooth phase into the hospital. And so like kudos to the different departments for doing that. I would like to believe that every department did that. So by the time that I started work on the first, we knew that okay, we have orientation from this day to this day. On the first day, we are meeting here. This is the expectations. This is the team I'm starting in, and so on and so forth. These are the days I'm on call. So rosters and everything was sorted during December. So that was really, really great. Loved that about the hospital. And I was able to, the internship coordinator was very, very efficient as well. I was able to move into DQ December. Because of course I was in Durban. So I was able to communicate with him, get a room, move my stuff from race to DQ, and then go home to visit my family in Limpopo before starting to work. So all of that communication and just the smoothness of the transition was really something that I was happy about. I started work on the 1st of January, New Year's. We were in the doing work. And I think internal medicine is intense everywhere. It's just one of those blocks. And I think internship is intense everywhere. But King Edward's is a tertiary hospital. So What that means is that it's a referral hospital, but we do still get walk-ins. So our calls, I think at most, if we admitted a lot of patients, would be like 15, 16, 17, 20. That's like a lot. That's like, yo, it was busy, but it was very possible to have a call where you're admitting 5, 4, 10, 12, and so on and so forth. So the patient load, personally, I don't think it's a lot. Yeah, there was an intake of, I think, about 64, 65. I'll check properly and confirm, but I know that in every department there's like about 15, 16 interns. So also the work was shared in a kind of like a fair way. It was still intense, but the work was shared in a kind of like a fair way. So we would have 12 calls for internal medicine per month. No, not per month, per block. So the whole block had 12 calls. But weekends are not a thing. So you would work Monday to Friday, and then Saturday, Sunday, we'd have something we call weekend cover. So you go to work, right? You go to work, basically. So we would alternate between, we had 2 interns in my unit, we would alternate between myself and the other intern. So it was also very possible to find yourself working 12 days with no break, like 2 weeks if you had a weekend cover in between. And post call, yeah, it's there wasn't a set time for post call. Post call can be 10 a.m., post call can be 3 p.m., and your calls start 8 a.m. the previous day. So, but I think what I noticed was it also depends on what team you're in. There were seniors who would, after the ward round, internal medicine ward rounds, after the ward round would, go through the ward work and see what you can leave for tomorrow, whatnot. Unfortunately, yeah, I didn't have that luck. So we would stay and work and work and do the LPs and do everything post call. We would leave very late some days, but yeah, we got through it. So that was internal medicine. It was a bit hierarchical, like you feel that you're an intern. And this is a rich, and this is an MO, and this is a consultant, So I think maybe it's because it's a tertiary hospital, but it's the hierarchy of medicine. I think in internal medicine, you really see it's very clear. And one last thing about internal, I think just one thing that I was worried about going to King Edward's was I had heard, stories about racism and toxicity, whatever. And I think for me, it was the first time ever that I belonged to a minority group. So maybe right now in a department of like 16 people, there's only like 4 Black people or so. So I didn't think that it was like a thing until one time. And I'm sharing this because I think it's important to know, you know what I mean? Especially when certain spaces are known for certain things or like certain you get. So the only time I really, really experienced something similar to that was in a ward round post call when it was myself. I was the only African Black/intern. And this consultant, at the end of the round, says, so interns, where did you study? But she's not addressing me. She's addressing the other 2, right? And at first I thought, okay, maybe there was like an error. But she asks another question again, and she's literally looking at someone through me. I was just like, okay, I didn't know you could be invisible. But otherwise, I haven't really. I think that was the only time where I felt like, okay, all right, this is what's happening, or this could be what's happening. But otherwise, I haven't really experienced it per se. Other than that, and then briefly going on to Pete, I've
Sorry.
done.
Sorry. Sorry, Dr. Mabulana, sorry to interrupt you. I just wanted to do a quick intro of Dr. Harikaran, who has joined us. So, Dr. Harikaran, if you can just kind of say a quick hello. We've kind of structured it in that Dr. Ramabulana is going to talk about first year, and then if you could please kind of give us an idea of second year internship. Dr. Harikaran? Sorry, your mic is off.
Can you hear me now?
Yes, we can.
Okay, good evening, everyone. So sorry, I may have a bit of difficulty. There is a bit of noise in the background. Um, yes, it's an honor and a pleasure to be here tonight. So I'd be very happy to answer any questions about second year. I think Dr. Tinga has done a fabulous job about explaining first year very well, and from what I gathered, and I'm happy to answer any questions that you have.
Okay, thank you very much. Sorry, Dr. Atinga, you can continue.
All right. So after internal medicine, I went to pediatrics. Personally, I didn't enjoy it. It was a very, for me, hectic and, with a bit of toxicity there. I think it got to a place where, as interns, we would go to work and have this common sentiment of just anxiety. You know what I mean? It really wasn't the healthiest space for me personally and a couple others that, we would talk to about, what's going on at work. Yeah, it really wasn't the healthiest working environment, but we got through it. There are short calls and long calls. A short call at King Edward's, you basically work from 8 a.m. in the morning until 6 p.m. And then a long call is 8 a.m. in the morning until 9 a.m. the next day. And post call is post call with PEDS. It's not like internal. So at 9 a.m. you hand over, you go home. So that's one thing I really enjoyed about pediatrics. In terms of teaching, I forgot to highlight that with internal medicine. With internal medicine, we of course would learn during ward rounds. You are seeing patients, during your calls. You are seeing patients at clinic. And there are presentations that are done for medical emergencies, I think on Thursdays. Yeah. So as interns, you make a pair of two and you're given a topic to do a presentation on, and so on and so forth. That's the bulk of the teaching. And then in terms of pediatrics, the first 2 or 3 weeks, there are presentations that are done in the afternoons, and then after that, throughout the whole block, there's like ambulatory sessions that we now present as interns. So there is quite a lot of teaching. You do learn during your ward rounds and so on and so forth. There's a module that we did in severe acute malnutrition where you go for like a session and then you do an assignment and you get a certificate for completing that course. So that was one other good thing. Yeah, so that's it about PEDS. You have about 13, 14 long calls, 12, 11 short calls. And then it's divided into two. The first half of the block, you are either at nursery or pediatrics, and then you swap halfway. So that's pretty much it. There is a lot of helicopter parenting where you feel like, you just have someone hovering over you and you don't really have the space to breathe and think and, you know what I mean, like feel like a doctor doing what doctors do, you know. Even in internal, I forgot to mention, it's a tertiary hospital. So you do end up a phlebotomist, you do end up a clerk, you do end up a porter, and such things sometimes. So those are things that can happen or do happen, where you just go to work and feel like, hey, you're just a phlebotomist or you're a porter or whatever. And then lastly, I'm currently in Ops and Gynae. So far the healthiest space I've worked in the hospital so far. I've started in Ops. I haven't done Gynae yet, but in Ops you work 3 days. So that is from 8 a.m. to 5 p.m. And then, so you work 3 days back to back, and then you work 3 nights back to back. So that is 5 p.m. to 9 a.m., sorry, the next day. And then you have 3 days off, including your post call. So it is quite intense, honestly. It's labor ward, you have Caesars, you have all of that. But I think the 2 days of rest just sort of like allow you to have some bit of breathing time. We do have ESMOs at the beginning of the block where you're taken through management of obstetric emergencies and, skills, procedures, and so on and so forth. So far, it's been good. It is intense, but you do get through it. So I think for now, that's what I have to say on the blocks.
Thank you so much. So, Dr. Harikaran, if you could just run us through the blocks that happen in second year and how many calls there are in each block, how the environment is, and that kind of stuff. Yeah.
Okay, it would be my pleasure. So in second year, we have quite interesting blocks. It's orthopedics, anesthetics, and we also do psychiatry. Those are each 2 months long. And then we do 6 months family medicine rotation. Our site of choice is Wentworth Hospital. So with okay, I'll go through each one systematically. So with orthopedics is a very nice rotation. You get a lot of exposure to putting props, reducing fractures. You have a lot of exposure and experience to actually being very hands-on in that rotation. The calls are not as bad. You have calls where you do cover different departments. You cover the wards, you cover there's you also get some theater time depending on how many interns are available. So with our group, we were a short amount of interns. So we did not get that much information, that much theater time. But in terms of clinical exposure, you get a lot of clinical exposure. Wards are very nice. You cover the wards on a weekend and you tend to see a lot of patients, especially in I4B. There's plus minus 30 patients there. But you find a way. I think it's important for you as a group to establish exactly how you're going to cover each area and to divide the work, because if you divide the work, you make it more tolerable for each person, and you can set more realistic like goals in terms of what you're hoping to achieve through the entire rotation. So with orthopedics, you do about maybe plus minus 1 or 2 calls per week, and that equals to about 4 to 5 calls per month. Sometimes you expect it to cover on weekends. It's not that you don't work every weekend. I think that pretty much sums up orthopedics. In terms of the seniors and the team, the orthopedics team, every morning you have a meeting that you attend. And this meeting basically allows you to present all the patients that you've admitted overnight. And this gives you such a great exposure to the different conditions, the way you categorize them, you learn all the different classification systems. So it's quite interesting, and you also get quite a good academic feel for the rotation, because you also have to do these presentations. You allocated a specific topic and you present in the morning meetings. It was really a wonderful experience. I must commend Dr. Rankin and Dr. Arnold. They're running quite a good department there. There was no bullying. There was no. The seniors were always willing to help. If you always, like, say for instance, you're not sure of something, you always discuss the patient, and they're very willing. And even the consultants in that department, you can always go to them and you can always discuss the patient with them. You don't feel scared or intimidated to speak to even a consultant in that department. So that was very good. Then in anesthetics, that was one of the best rotations. I think in general, second year is much better than first year. First year, you go through a lot as an intern. You have days where you cry and you work excessive amounts of hours. With second year, you tend to sort of adapt very well, and you tend to actually enjoy the experience of being a doctor. You see these specialist fields, and you finally, at this point, I know it's still early in your career, but you finally at that point where you now feel a bit confident with when you're managing a patient, and you don't feel as scared. And sometimes you will find something that maybe someone will overlook, and it's actually, you get commended on things like that. And you also get commended on how much of effort you put into the rotations. So going back to anesthetics, anesthetics is a wonderful rotation. I actually was sick during anesthetics, and I had to miss some of the rotation at the start. However, Dr. Jitu was amazing in terms of allowing me to get back up to speed. Anesthetics is a very high intensity rotation. There are tests, there's presentations, and basically it's a very structured program from day one. I think you spend the first 2 to 3 days just with Dr. Jitu, and she'll take you to theater, and they have all these case scenarios, and she'll run you through basically how you're going to do your spinals, how you're going to do your general anesthesia. And it was very, and they send you an anesthetics handbook as well. And that handbook becomes basically your lifeline. And it's also a very great resource that you're going to take forward with you into community service as well, because when you're out there on your own, you're going to rely on that to basically assist you in performing all your anesthetic procedures well. So during anesthetics, we got exposure to doing spinal. So initially, you will start where a senior will be there and they'll be standing by with you. But after a few calls, they're going to leave you on your own, and you're going to take charge, and you're going to do the spinal on your own. So you're going to see your patient, you'll do your pre-op, see your patient, assess them, their fitness for theater. Once you are happy with that, you take them, you wheel them literally into theater, you do your anesthetic, and you basically are so independent in that time. I've had calls where I was left on my own. I know maybe that might seem scary to some, but once you get to that stage where they trust you enough, you go into theater and you're managing the case basically on your own. And in terms of general anesthesia, we got the opportunity to intubate a lot of patients. They teach you how to set the ventilators. So it's all practical things that you're going to take forward with you. And it's going to be scary but exciting at the same time, because you're going to learn so much. And you'll actually be amazed at yourself as to how much you've grown in that rotation. So that was a very lovely rotation. The department is very good as well. It's a bunch of high functioning individuals, so they really will push you to the most, but it's sort of, they're pushing you because they know you're capable of doing these things. They don't force you to do anything, but it's again, how much of interest you're showing, and they are ever willing to, go above and beyond for you. As a group, our group did very well. They also have a simulated day where they actually have like this little fake patient, and they also they hook it up to monitors, and you are basically in charge of running the entire scenario. They actually do it in a theater, so you get the full feel of if you are taking charge of a patient in terms of general anesthesia, what would you do? And it was a very wonderful experience. So that was anesthetics. The calls for anesthetics tend to be a bit hectic. Sometimes you do go throughout an entire call without getting any sleep. It's not often that you would have those calls. However, those calls do happen, and it's something that you need to be aware of, I think, initially, because I know, like, when we think of calls, we think of, at least getting a couple minutes of sleep, at least an hour of sleep. But there's some calls where you just don't get any sleep at all, and you're expected to perform. And so with anesthetics, you do get a pre-call. So you do get some time off before your call, and then you do your call, and then you get a post-call as well. So that's extra beneficial. That's the only rotation where you get a pre-call. So enjoy the time off. And then we also did psychiatry. Psychiatry was a wonderful rotation as well. Um, so with psychiatry, it's much more, the hours are much more flexible. You have a lot of spare time actually, if you are able to finish your work completely. They do have a system where one intern and one senior stay on as the cover for basically the clinic, and you would stay one afternoon per, like, depending how many interns, but basically we would stay like one afternoon in the week. And during that time, you will see patients. So with psychiatric patients, you do your calls in casualty. It's normal casualty calls in King Edward. So it basically, you will see you will see whatever patients come through, come in, and then you will refer them to the relevant disciplines. So if it's a surgical case, you will see the patient, you'll do your bloods, you'll put up your line, you'll put in an NG tube if necessary, you'll do a catheter if necessary, and then you refer to surgery. Or in the same instance, you'll prepare the patient basically for orthopedics or any other specialist discipline. And so that's your casualty calls. Casualty calls tend to, so on a weekend, the way it was structured for us were 2 interns were on call on the weekend, on a Saturday specifically, because it tends to get a bit busy. However, on a weekday, it's entirely you on your own. But you'll find that the nursing staff are very, very helpful in allowing you to, like, to make sure that you have time to eat, to rest. They will actually tell you, you know, doc, I think you should go and have a small break now. So it's really nice that you have people that are concerned about you. And in terms of psychiatry itself, so the department is run where they have a 10-bed male ward, and they have a 10-bed female ward. However, usually the male ward tends to get more full, and they tend to take a maximum of 20 patients. So that's split between males and females. So sometimes you may have like discrepancies where you have like 5 female patients and 15 males, but that's how it works. And then you will go in, so there's different subcategories within the discipline. So you have neuropsychiatry, basically, or neuropsychology. That is where they tend to do this consults for cases where the patient has a psychiatric condition. However, they also have another comorbidity. And it's also important there, when you're seeing those neuropsychiatric patients, to exclude other medical causes of illness, and to exclude all those other general medical conditions prior to making that psychiatric diagnosis. And then they also have a consultation liaison, basically CL. So that is the senior there will take you around, and you will see patients that are basically what we term outliers, but they basically being managed by another team. So maybe they managed by internal medicine, but they also have a psychiatric concern. So you will go and see those patients. I think that's psych. And then the clinic, you get a lot of outpatients coming there. With psychiatry, you'll see that due to the social circumstances, you have patients that are basically it's a revolving door system. Patients tend to come in and out. You'll actually, unfortunately, be seeing many of the same familiar faces over and over again. So you'll basically stabilize them in the ward. You'll see them make some progress. You'll get them healthy and send them back home. But unfortunately, they do tend to come back. Sometimes substance abuse is a very, very big issue. So that's why many of them end up coming back to us. I think that covers psychiatry. I don't think that there's anything else that I'm missing out with that. And okay, so now we just recently started our family medicine rotation. I think that's the scariest one from all of them, because you're doing 6 months. However, it's again about your outlook. So Wentworth Hospital is a huge culture shock. It is a big, big culture shock for everybody. I think as much as people say how bad it is, you don't truly fully appreciate how bad it is until you get there. I would love to say good things about it, but I would like for you to also know the truth. There's instances where we've been sworn at, verbally abused, almost to the point of physical abuse, which is unacceptable. And we had to actually consult our site manager and things like that to actually come up with an SOP for verbally abusive patients and physically abusive patients, because the community there it's completely different. It's something that you've never experienced before in your life. Um, they literally do not understand. Even when you try to reason with them, there's patients that don't get seen. So MOPD allows a lot of patients to walk in from local clinics, even just walk into the hospital, basically. So you tend to have a huge patient load there, and there's not enough doctors, to be honest, in comparison to cover that immense patient load. So if you have plus minus 5 or 6 doctors in acute OPD, you have about maybe 50 to 60, sometimes even 100 patients that's waiting there. So you can understand, if you do the maths, between 8 and 4, you can never see that many patients, right? Most of them require consultation with like King Edward. So that's basically what family medicine entails. It entails you having to understand the condition, and if you can treat it, you treat it. However, if you cannot treat it, you need to know when is the appropriate time to refer a patient and how to get them the actual help that they need, how to refer them, the process, to give them the correct referral letter, but also to consult with the specialist discipline and to get the patient across safely. So in many instances in acute OPD, we have to actually VULA. So we VULA and consult whether it's King Edward internal medicine, King Edward surgery, basically all the different disciplines. And you'll understand when you are there that it does take time to do these things and to get the patients the correct care that they seek. So in that sense, you will never be able to complete and finish that crowd of patients that come in on one day. So what happens is the patients that are not seen, they get carried over to the next day. So it's this constant battle of trying to deal with the patient load. We were honest, to be honest, we were told not to try to finish the crowd, but to actually help those that that we see. So if you see 20 patients in the day, as long as you know with your heart and you've tried everything and you've done everything for them and you've got them the appropriate care, it doesn't matter that you didn't see every patient, because in Wentworth, you definitely cannot see every patient. The same applies for accident and emergency. So in accidents and emergency, that is where we do our calls in the evenings. So our calls are structured basically on a weekday between 4. So you'll start your day basically in the department at 7:30. On a Tuesday and a Friday, we have academic meetings. So on a Friday, we have CME. You attend the meetings. You then move to your allocated stations. So there's different departments. So there's gynecology, there's acute OPD, there's chronic OPD, there's Masibambisane, which is the HIV and TB clinic. And there's also the local clinics, which are Cato Manor and Clearwood clinics, where you would be allocated to. And there's also interns that cover the day shift in accident and emergency. So you report to your workstation. You work basically from whatever time so usually 7:30 till 4. At 4 o'clock, you go for the handover at accident and emergency. And at AME, basically, you will get taken around and shown all the patients that were seen during the day. And then you will make a list of what needs to be covered and what needs to be done at night. The call will then last from 4 till the next morning. So usually on a weekday, it's till 7:30, and then you do a handover again. However, on a weekend, before I get to that, from 7:30, you then expected, after the handover, to now report back to your station, your workstation, till 10 o'clock. And that is basically you working your hours. That's how the calls work there. On a weekend, you're lucky because the call starts at 6 o'clock and then it finishes at 8 o'clock the next morning on a Saturday. On a Sunday, you are expected to go to your workstation and work between 8 and 10. So your post-call time is 10 o'clock. With Wentworth, so I've only rotated through A&E, acute OPD, and at the moment I've just finished my Cato Manor rotation. Next, I'm going to maternity, and afterwards I'll go to chronic and Masibambisane. During this 6-month rotation, you get 11 days of leave. So that's, you can choose to either split your leave into two, like 2 5 days, or you can take the entire 10 days in one go. So it's completely your choice there. And so far, I don't want to only say bad things about Wentworth. I think it's also a chance for you to, go back and fill in the gaps in your knowledge. So it's preparing you perfectly for ComServe, because you're going to be on your own in ComServe, and they make that very clear. So you need to be able to look at each rotation, whether it's internal medicine, surgery, pediatrics, obs and gynae, and you need to identify what are your strengths and what are your weaknesses. So whatever your weaknesses were and you didn't get exposure to in your first year, this is now the ideal opportunity for you to go back and for you to go and make up specifically in those areas where you have a deficit. So say for instance, if you did not learn how to put up a CVP in your first year, this is now the perfect opportunity in A&E to now go and hone in and, utilize the resources. And when you have an opportunity that presents itself, you take advantage of that opportunity to make yourself more independent. I think that sums up internship in general. Wherever you go for internship, it's not dependent on the setting, it's dependent on you. There's nobody that can do it for you. It's entirely up to you. It's what you make of it. You can be in the most well-stocked hospital, you can have the best calls in terms of it being quiet, but how much are you actually learning? Sometimes the calls that are the craziest and the ones that you didn't get any sleep on, those are the memorable things, because that is the time where you had to enlist all your strength, and you had to think outside the box. You had to improvise. Sometimes when you are, you don't have stock of something, you have to improvise, use makeshift things. I mean, for an example that we had is when you
Sorry,
had
Dr.
a big, yes,
Sorry, I'm so sorry to interrupt
yeah,
you.
sure,
But we are running just a bit late, and we do still have
sure.
a few topics to hit.
Okay,
So and there are some people who've sent a few questions as well. So
okay,
if we could just
perfect.
quickly jump to the DQ, and then after that we can go into like salaries and then questions after that.
Okay. So in terms of the DQ, I honestly am not the best person to ask because I stay at home. So I am from Durban, and I have not stayed at DQ.
Yeah,
But what I can gather is that at King Edward, I remember people talking about the DQ there, and
yeah,
they said that it was good. It was just that there was problems with hygiene. However, they did enlist help, external help to clean up the specific rooms, and then they used it afterwards.
yeah. Dr. Atinga, if you could speak on it, because I know that there is a video that you had shared with us as well.
Could we rather? I think the video sort of like wraps up everything in a brief way.
Okay.
We rather just play the video.
Okay, no, that's perfect. Pilani, if we could just get the video up, just for everybody to see the video, and then after that, Dr. Atinga, if you could just go straight into salary. Thanks.
I think there's a problem with the sound.
Is it possible to share with sound plan?
Saying hello, sorry.
I was just asking, is it possible to share with sound?
Yeah, I did. Is it not audible?
There's a chapel there. The building there's a chapel. People can go pray.
Okay, we can hear it now.
Oh, okay.
And there is the pool. This is the view, right? And I'll show you inside now.
Yeah, they all left. But I prefer the stairs because, yeah, I don't trust in this in general. So this is first floor where I stay. Right. Okay. There's this place here, but none of these machines work. You can wash there and hang there. Right. This is how some of the places look. Common fridges, kitchen, stove, and like some common sitting area, right?
It's not the longest corridor. There's the pool. This is nice, right? So these are ironing boards that we don't use. This is the bathroom. So it's like, yeah, they, you know, we have to be honest. We have to be very honest. Yeah, this is the one that's the best. But it's not necessarily attractive. And then the toilets there. Okay, shaving there.
The kitchen, it does have a common fridge and some drawers and some cupboards. This kitchen doesn't work. This stove does work. The oven, I don't know. Yeah, there's that basin and that. But we have to be honest, you know. Right.
This is the room. It's very little, but we make it work. Okay, so this here is my little kitchen station. I've just tried to like get this piece of furniture to fit everything. This is my stove. This is a spice rack, so it has everything. There's a microwave because there aren't microwaves here, and that's my little breakfast. Sorry, that's my little breakfast station there. Yeah, and I have this thing of water because the kitchen is very far, ish kind of. Then I came with my own fridge. That's the fridge I was using as a student. And that's my little bed. It's a single bed. I found this chair. It has wheels, so it kind of like it's that kind of vibe. And the room comes with a bed, only the bed and this table and this closet only. So like the hooks, the furniture, microwave, everything else you bring yourself. So yeah, you sort of just find ways to make it work, and make it as homey as you can make it. But yeah, even this bookshelf I bought myself. So yeah, you just try and make it as homey as you can.
Thank you.
Wonderful. Thank you so much. We will share the video on the group just in case you missed something. But thank you so much for that video, Dr. Ating. So if you could please just go into like salary, are there any packages that that they have that you're able to receive? Are there any extra allowances? Yeah.
I had shared my pay slip with Sarah. I don't know if you can just show it on the screen as well. So at King Edward's, we don't have rural allowance, we don't have crime allowance, we don't have any allowance. We just have the salary as is. DQ is 900 rands per month, so that is including water and electricity. I think for me personally, you know, as fellow Black children from the dusty streets of the rural areas, would relate. We have quite a lot going on. We have a lot of responsibility and so on and so forth. So I'm born to a single mom. It didn't make sense for me to take an option of maybe renting places around that like could range between 4K, 8K, so depending on how comfortable and big they are, when there is an option to like, squeeze in myself into the space for just
Yeah.
a year or two and pay 900 rands for water and electricity. I think it's a bargain. It's not the best conditions, but we are all different and we all have different stories. And if you are like me, and me, I'm from Venda in Limpopo, born to a single mom, firstborn, I have young siblings. It's I think it's a
Survival option.
it's a reasonable decision to make.
Mm.
So that's my puzzle, that's my pay slip. So my net salary is 48,165, and this is after deducting race fees. Yeah, that's
Okay.
where we
No, those are solid numbers.
are. They are.
Solid numbers. Okay, thank you so much. So we do have a few questions because I'm kind of just going to hop between you and Dr. Ravona. The first being like, how would you say work-life balance is, especially in terms of like how your mental health has been throughout?
Okay, I think I can go first because I'm already unmuted. So if you know Atinga, I went through medical school doing medicine. I'm an artist, I perform, I'm an entrepreneur, you know what I mean? And throughout the 6 years in med school, I was able to sort of like maintain balance by doing all of these other things. Those things kept me sane. But the first 6 months of internship were so hectic that all I did was go to the hospital, work, come back, sleep. Go to the hospital, work, come back, sleep. Like Durban has so much to see, so much to experience, so much to do. But I think it's the internship, guys, is for me, and I'm sure many others, it's exhausting. You are physically exhausted because there's a lot of running around, there's a lot of chasing, you're up and down to x-ray, you're up and down to the lab, blood bank, there's a lot of walking. It's labor intensive. It's physically exhausting that sometimes you come back and you have to decide whether you're going to eat or sleep. You know what I mean? That's how tiring it is. And mentally, I would say that over and above, and this is just a piece of advice, go where you have a support system, because there are days where you're all going to break. There are days where, especially in internal, you are seeing so many deaths. You know what I mean? There are days where you on my 7th day of work, sorry, just a quick story. My 7th day of work, so first week of work, I got a needle stick injury. And this lady had a viral load of about 600,000. And, there are such days where it's jumped. So just go where you have a support system. I don't think anyone has done 50 internship and felt that it's a breeze, but it's just, I guess, part of the thing that we all have to go through. But go where you have a support system, because to come back and cry alone is
hard.
It's very, very sad, So just go where you have a support system. It's tough everywhere, but it's a thing that we have to do. It's part of the journey.
Sorry that happened. Dr. Ravona, if you could please just give us an idea. You mentioned that in anesthetics they do have an assessment. In which other blocks do they have an assessment? And like, is there like a kind of failing in the other blocks?
Okay, so with anesthetics, there's basically sort of like an entrance test. It's just to assess how much you know. And then at the end of the rotation, there is another test. It's all the answers are basically things that you would have covered in theatre. So specific cases in theatre, you would be able to sort of pick up where on like that this question is a possible question at the end. It's also a lot of the questions are a lot. It's based on a lot of mathematics. So it's basically for you to calculate, drug doses and to know the side effects. So those sort of things. The tests were there just to, I think, make you read the handbook basically, because a lot of people would be given the handbook and I think you wouldn't actually take heed and read it. But because you know that there's a test, you have to unfortunately
Go
study
through
for the
it.
test. There's no failing really. I think Dr. Jitu goes around and she even like helps you sometimes during the test, and she just makes sure that you're on the right track. If she sees that you're writing something ridiculous, she'll be like looking at you and come to you and say, "Are you sure that this is the correct answer? Do you remember like a specific case?" Like, she sort of like helps you out. So it's not such a formal test, but it's just an assessment to see that you have, progressed, you have learned throughout the rotation,
Yeah.
and that you're a safe doctor, that you're safe in prescribing and things like that. Orthopedics did not have any any formal rotation, any formal test, and psychiatry, no, there wasn't. There wasn't anything else there.
Okay. Okay, thank you. And I think this can apply to both of you, knowing that KZN is majority Zulu speaking. For somebody who knows not a drop of Zulu, would they survive in King Edward?
So I think I could take that one. So my Zulu is very minimal, despite having done the UKZN course in Zulu. I mean, we only learn medical Zulu, which you can try to use on a patient, but there is a point where now the patient has started answering you things, and it's like, but you're not sticking to the script anymore, and it becomes like I can recognize and I can pinpoint, oh, that's, yes, I know, I can understand. So I think your understanding of Zulu gets better. However, when you're in the hospital, there's always somebody there that can assist you. Sometimes you'll find assistance in nurses, but I promise you, you'll never always have a nurse constantly with you. So sometimes you'll rely on maybe the closest person, and sometimes even other patients will assist you, and if they see you struggling. Sometimes you're just asking a patient basically for how they're feeling today, but sometimes they deviate with their answer, they give you a long answer, and the patient next to them will sometimes translate and say, doc,
Yeah.
this is what they're saying. But I've always found somebody to assist me, especially in instances where something like consent is important. I will always ask a sister or ask somebody, another healthcare professional, to come and sit with me and make sure that the patient understands what they are signing for, especially for procedures. I do not take chances with that. That is 100%. You need somebody to translate for you, know your limitations, and don't allow that to basically stop you from or halt you from what you can do. You still can learn more. The opportunity is there. When the opportunity presents itself, you have a friendly patient, they'll teach you a few more, a
Word.
few more sentences and a few more
Yeah.
lines. And nurses are always there to help. So I've made it to second year, so clearly it's okay.
Thank you. We have actually run out of time. I do want to ask in the group if there's anybody who would like to just raise their hands, ask a question or two. Okay. Doesn't seem like there is anyone. Oh, I do have one. Sorry.
I'd like to just add one more thing.
Yes.
Well, King Edward's Hospital has sort of like rebranded. It's now Victoria Mxenge Hospital. So it's not.
I'm sorry, Dr. Ravona, if you could please just close your mic for us, please, because there's a bit of feedback. Thank you.
Yeah, so I think it might be Victoria Mxenge on the options, because it's not necessarily King Edward's Hospital anymore, just to put it out there.
Okay, thank you very much. And there was a question actually that was sent in the chat about like, was it part of your choices? How high up in the choices, I guess, as well? Like, what's the competition like when it comes to placement?
I could take that one as well. King Edward's was my first choice. I needed to be in Durban, and yeah, I got it. So I think I love the people who put it as their first choice managed to get it.
Okay.
I also put it as my first choice. Yeah.
Okay. Thank you so much for your time, and just for your review. It's been very insightful. It's definitely like cleared our minds. Now we know what we need to know, and we can make an informed decision. So thank you so much for your time, and yeah, thank you very much.
Thank you for having us.
Thank you. So the next session, we will start the next session at 5 past as well, in the same way that we did for this one. So if you could just, grab a quick water or something like that, and at exactly 5 past, we will start.
Must I leave? Are you kicking me out?
Thank you so much for having us.
Bye. Thank you so much. All the best.